that you base that off on the location of tear, and as well as the gross appearance of where the dissection is. But sometimes, even with the best of imaging, the dissection, the so-called entry tear is not entirely clear, even with the highest resolution scan. So that poses a sort of a dilemma. Again, one for the common man, not
Sure, sure. No, they're very eloquent points and they're very well taken. I mean, the whole point is there's huge confusion here. When I use the Stanford classification, I don't put in a tear-orientated approach for me. Because if the ascending aorta is involved, even if the tear is distal, we know that the proximal complications are life-threatening. So we can argue about how you manage them surgically, but they need surgical management. So for me, for the type Bs, even if there's a small extension into the arch with a distal tear, they can still run quite a benign course. Now, when you bring that group of patients into the category of non-A, non-B, you've really muddied the waters as far as I can see. And my worry is that the recent papers on this, it seems to me that people have struggled a lot for patient numbers because they're really, really small. So if you said, okay, a non-A, non-B is just a tear in the arch with no ascending aortic involvement, let's look at that group of patients and see the outcomes, you'd have a very, very small number of patients. But the point is that it's surprising when you look in the literature, 2 seminal papers with non-A, non-B in the titles have completely defined what non-A, non-B is in terms of the way that they're going to look at the patients. So we're no further forward, really.
Yes.
I don't want to muddy the waters any further than it already is. I agree with your concern about the more proximal tear, but I think the construct or the entity in which it occurs makes a big difference. I think my concern is increased if I've got a patient with connective tissue disorder. And if I've got a non-A, non-B and the ascending aorta is 3 centimeters, I have one level of concern, but if it's 4.5 centimeters, I think the natural history is probably going to be a little bit different. So it's even more complicated.
No, that's absolutely right. But you know, I think one of the drivers, this is exactly why Warrawong picked this talk, bless him. But one of the things that I struggle with sometimes is that, you know, we'll get a patient that's been put in a CT scan and they've got descending dissection with a distal tear with proximal extension into the arch for a small way, and the radiologist will categorize that as type A. And then as soon as you get a CT scan report, a type A dissection, then medico-legally everything becomes very, very complicated. So I think my stance is, you know, keep it simple, intrapericardial aorta or not, and then there's obviously a really big heterogeneous group, like you say, depending on their status, presentation, aortic size, that we need to take into account.
Okay, so we should move on to the next session.